Good evening, everyone. So, this slides have been provided by Dr. Reddy's, and I'll be speaking on the hand-foot syndrome. So, prevalence of HFS, as it is widely known, it ranges between 5 to 60% based on the different drugs used, and in some studies it has been reported up to 80%, and depends upon the agent used, the formulation, how it is used, bolus infusion, and oral intravenous. It depends on all that. So the common agents responsible for HFS include the, as you know, in clinical practice, the most common agents include capecitabine and 5-FU, but other agents like cytarabine, gemcitabine, liposomal doxorubicin, docetaxel have also been reported, and we see in clinical practice, but not as common as that with uh, capecitabine, 5-FU, and or other TKIs. So how do we grade it? So the grading ranges from 1 to 3. The grade 1 will be minimal skin changes of dermatitis with altered sensation that do not interfere with activity of daily living. And grade 2 will be skin changes presenting with accompanying pain, which interferes with activity of daily living, but skin surface remains intact. And the grade 3 will be ulcerative changes and with severe pain interfering with activity of daily living. And there can be blisters, peeling, and edema. So this is the grade 1 HFS, and on the right side we have grade 2 HFS with peeling of skin and dermatitis. And this is grade 3 with severe blisters, ulceration, as you can see. So what is the difference between hand-foot syndrome and hand-foot skin reaction? So there is some difference between the HFS caused by the traditional conventional cytotoxic chemotherapy agents and those caused by the multi-kinase inhibitors like regorafenib, sorafenib. The difference is that in the HFS caused by TKIs, it's more on the pressure points, and there's typically a surrounding red halo and the bullae and calcareous superficial. When the traditional cytotoxic chemotherapy induced HFS, the picture is of more diffuse, symmetric, confluent edema and erythema of palmoplantar surfaces, and the bullae are usually deeper and often with diffuse discommission. And again, in the TKI-induced HFS, it's more in the feet, lower limbs, and in the conventional cytotoxic agents, it's more on the hands rather than the feet. And in the TKI, it's after 2 to 4 weeks, and in the cytotoxic chemotherapy, it can happen from 24 hours to up to 10 months. And the pathophysiology in the TKI, it is related to the macrotrauma, and because of the multiple VEGFR and other PDGFR inhibition, it's not able to heal. The skin is not able to heal. Well, for the cytotoxic chemotherapy, the mechanism is that secretion into sweat glands, local accumulation, and this causes the degeneration and necrosis of eccrine glands. So as you can see in the picture on the right side, the HFS is more on the pressure points, and in the middle one, it's more diffuse one. And one more thing with taxons that can involve also the dorsal surfaces, as in the picture on the left. So what are the preventive measures for HFS? First and foremost is the prevention. So with appropriate guidance to the patient, it can be not completely avoided, but chances can be reduced. So this includes avoidance of irritation, avoidance of mechanical stress, avoiding chemical stress like skin irritant solvents with directly with hand, and also we should see if there are any calluses or that before starting chemotherapy that can be taken care of before only. And urea 10% cream can be used, but very clear data is not there. But most of the times, the use of it is helps in the prevention of HFS. And when already the patient has some HFS, what is the management? So for grade 1 and 2, usually for grade 1, usually with routine care and skin emollients, it can be handled. But for grade 2 and onwards, grade intolerable grade 2 and grade 3, use of topical high potency steroid ointments or the local anesthesia in the form of lidocaine patches, along with urea creams can be utilized. Also, for the grade 3 and grade 2, the doses have to be the indication for which the chemotherapy is being prescribed, the necessity of that, and any potential possibility of dose reduction have to be considered. And after 2 weeks, If the symptoms do not improve, then dose interruption or discontinuation as per the clinical scenario may be required. So treatment algorithm, so grade 0, 1, 2, 3. So I told initially prevention, moisturizers, and for grade 1, uh, monitoring and use of emollients including containing urea, and for grade 2 and grade 3, use of corticosteroids or local anesthetic creams, and reduction of the dose of the chemotherapy as appropriate. And so other newer agents which have been used, Pramaxine is a morphine-based surface anesthetic agent, and it minimizes the danger of cross sensitivity in patients allergic to local anesthetics, and it relieves itching and is well tolerated. And this is by the stabilization of the neural membrane of nerve endings and reducing the itching sensation. And urea, as I told, in both the prophylaxis and treatment, so it acts as a humectant that increases the hydration of the stratum corneum, and moisturizing with it 3 times per day prevents HFS, and has also shown benefit in treatment of this hand-foot syndrome. And as we know, it is keratolytic, anti-itch, and anti-inflammatory, and dissolves the intercellular matrix of cells of the stratum cornea, thereby reducing the dead skin buildup and helping to get off flaking or skinning skin. And the clinical data to support the use. So studies have been done, meta-analysis, which shows that the prophylactic subgroup patients have a lower incidence of HFS grade 2 or more with a risk ratio of 0.72. Also in the JCO publication, the use of urea-based cream was seen in the sorafenib associated HFSR. There's a 12-week incidence of any grade HFSR was reduced by around 20%, and the median time to first occurrence was also delayed. So this has improved improvement in the prevention of HFS. Thank you.